Hello everyone, welcome to this quick review series. Today we are going to study about the management, the diagnostic part and the management part of deep venous thrombosis and pulmonary embolism. Okay, so the diagnosis part is divided into the investigative modalities are divided into three groups. One is non-imaging modalities, one is non-invasive imaging modalities, another one is invasive imaging modalities. Now start with non-imaging modalities. These include D-dimer, cardiac biomarkers, cardiac biomarkers. Remember, whatever I'm telling is mostly focused on the investigation of pulmonary embolism. Okay, because for DVT it is straightforward. We have to do a ultrasound, compression ultrasound of the lower limb, because most likely it is the lower limb DVT for which you have to do compressive ultrasound. If it is non-diagnostic or incompressive in the compressive ultrasound, you can go for MR venography. But rest of the things that I am discussing is about pulmonary embolism. Remember, the most common cause of pulmonary embolism is lower limb DVT. The thrombus from the lower limb it comes to the right side of the heart and it goes to the pulmonary trunk. Okay, and there it occludes the pulmonary artery. So that's why, if you understand the physiology, it is the right side of the heart that is affected because the right side outflow tract, that is the pulmonary artery, which is occluded. So the most of the whatever we are going to discuss about the investigative modalities is based on this physiological concept that the right side of the heart is predominantly affected. Okay. So non-imaging modalities includes first is D-dimer, second is cardiac biomarker, and third one is ECG. What you need to remember about D-dimer. So before understanding that, let's just see this. This is known as Wells score. This is known as a Wells score, likelihood score for pulmonary embolism. Forget about the DVT part. Just focus on the second part, that is the likelihood of pulmonary embolism. So whenever you are suspecting pulmonary embolism, if the suspicion is not very high, you can just put up this score. You can just put up this score, and you calculate the total pulmonary embolism score. If the score is more than 4, if it is more than 4, this score, if it is coming more than 4, then there is high likelihood that there is pulmonary embolism. This is known as pre-test probability. So if it is more than 4, the pre-test probability for pulmonary embolism is increased. So in this case, you can directly go for CT pulmonary angiography, which is the investigation of choice, for pulmonary embolism. This is the investigation of choice for pulmonary thromboembolism. If the suspicion is high, you can directly go for this CTPA. But if the score is less than equal to 4, then the suspicion is low. The likelihood is low, that is the p-test probability is low. In this case, we just want to rule out pulmonary embolism. Rather than confirming pulmonary embolism. So in this case, instead of going into a higher order investigation like CTPA, you can just do a serum marker, that is D-dimer. Why D-dimer is used? Because it has very high sensitivity. It has a very high sensitivity. That is, the sensitivity is more than 80%, for DVT, and more than 95% for pulmonary embolism. So remember, whichever investigation has very high sensitivity, that means they have a very high negative predictive value. What do you mean by that? That means if D-dimer is negative, that means the chances of having pulmonary embolism is very, very, very less. Okay. But if it is positive, because I told it is not specifically sensitive, so even if it is positive, you cannot tell that the elevation is due to pulmonary embolism. But because it is highly sensitive, if it is negative, we can almost confidently rule out pulmonary embolism. So whenever the pre-test probability or the likelihood is less of having pulmonary embolism, you can just do a D-dimer. If it is not elevated, you can just look for alternative diagnosis. But if it is elevated, you have to confirm the diagnosis by doing a CTPA. If it is not elevated, if it is normal, then you have to look for alternative diagnosis. Normal D-dimer levels are 500 nanogram per ml, 500 nanogram per ml. However, after 50 years of age, the values increases. After D-dimer, I have already discussed. After D-dimer, you have to remember about cardiac biomarkers. So these cardiac biomarkers are increased because there is strain on the right side of the heart. So there is increase in troponin I. Troponin I is a marker of, must be remembered, it's a marker of cardiac ischemia or infarct. So because the right side of the heart is affected, usually there will be associated right ventricular microinfarct, which will cause increase in troponin I. Along with that, there may be increase in brain type fatty acid binding protein, brain type fatty acid, or sorry, heart type fatty acid binding protein. There may be also increase in BNP and NT-proBNP. These are markers of cardiac dysfunction. Okay, so these are not very important. Then coming to ECG, it's a very important investigation in these patients. We'll be discussing the ECG changes in pulmonary embolism in detail in the my ECG lectures. But remember, the most common ECG finding is sinus tachycardia. The most common ECG finding is sinus tachycardia. S1Q3, S1Q3, T3. This is a specific finding, but it is found only in 10% of cases. It is found only in 10% of cases. Other findings include right ventricular strain pattern and RBPP pattern. Because I told the brunt of the disease is coming onto the right side of the heart, so you will get all the features of right-sided strain or right bundle branch block. So these are the findings. If you see this ECG, you can appreciate there is a right bundle branch block pattern. I'm not going to explain why it is a right bundle branch block like pattern, because this I have already discussed in my ECG sections. Okay. You can also appreciate the strain pattern, the STT changes. And here also you can appreciate that there is S1, Q3, T3. So this you can see a deep S wave in lead 1, that is S1. Then you have to look at the lead 3. You can find there is a deep Q wave, the prominent Q wave, so it is Q3. And also you are finding an inverted T wave, so that is T3. So S1, Q3, T3 is also present. Okay, so these are the findings, but remember the most common ECG finding is sinus tachycardia. Now coming to non-invasive imaging modality, first of all, ultrasonography. This is for DVT, and the ultrasound that you do is compression ultrasound. What do you mean by compression ultrasound? This is known as compression ultrasound. Remember, US is not for pulmonary embolism; it is done for to look for DVT, as I have already told. So what do you mean by compression ultrasound? If you see, in this case, here you can see the veins. It is the femoral vein. This is the common femoral vein shown here. So whenever there is a thrombus, usually the veins are compressible. If you give compression with the ultrasound probe, usually the veins are collapsible. In compression, normally veins are collapsible. Veins are collapsible. But here, if there is a thrombus, it will acutely dilate the veins, and the veins become non-compressible. So with compression, the veins will become non-compressible, and that is a feature of non-compressible. That is a feature of DVT. Okay. Sometimes you may get equivocal finding in ultrasound. In those cases, you can go for MR venography. In those cases, you can go for MR venography. It is done only in cases of inconclusive USGs. Now coming to the non-invasive imaging modalities for pulmonary embolism. So we'll start with chest X-ray. Chest X-ray, there are three findings that you have to remember. So this is known as Hampton hump. This is Hampton hump. It is a wedge-shaped opacity. That is due to the infarct. That is due to the infarct happening because of the arterial occlusion. Here you can see there is a focal oligemia. Oligemia means there is no blood flow. You can see there are no vessels on the other side. Left side you can see there are vessels, but here you can see there are no vessels. So this finding is known as Westermarck sign. Westermarck sign. This is focal oligemia. Focal oligemia. And one more finding is you can see this is enlarged. This is the right descending pulmonary artery, which is enlarged. And this is known as the Pallas sign. So these are some of the findings. There are so many other findings, but these three are mentioned in Harrison, so I am telling here. But remember, the most common chest X-ray finding is normal. So most common chest X-ray pattern is normal X-ray. This is most important point to remember. So most common ECG finding is sinus tachycardia. Most common chest X-ray finding is a normal X-ray. Now next thing is CT scan. This is the most important investigation or the investigation choice of CTPA, CT pulmonary angiography. CT pulmonary angiography. So what you will find in CT pulmonary angiography, CTPA, you will find that there is a filling defect in the pulmonary artery. So this is the main pulmonary artery you can see here, and you can see this is a thrombus. This is a thrombus, and this is of course it's a massive or saddle thrombus. Massive or saddle thrombus, and it is occluding the bifurcation of the main trunk. But in second case, it is a peripheral thrombus. It's a peripheral thrombus or thrombus in the branch of pulmonary artery. Thrombus in the branch of pulmonary artery. So you will get filling defect. Filling defect, and this is the investigation of choice also. If you do thin cut CT, that means each cut is of less than 1 mm, less than equal to 1 mm. Here you can see sixth order branches also to look for the peripheral pulmonary embolisms. Sixth order branches also you can see. Okay. Many times the CT is done to look for three important causes of chest pain. Those three are acute coronary syndrome, aortic dissection, and pulmonary embolism. This is known as triple rule out CT. Triple rule out CT. In this, what we'll do is we'll do a scanning of pulmonary artery to look for pulmonary embolism. We also take scanning for aorta, look for aortic dissection, and also coronary artery to look for acute coronary syndrome. So this is known as triple rule out CT to rule out the acute conditions that will cause chest pain and cardiovascular dysfunction. This is known as triple rule out CT. Will scan three important vessels. Okay, so that is about the CT. Now the next thing is 2D echo. Oh, sorry. Okay, so 2D echo usually we do bedside. So 2D echo, what is the finding in 2D echo? Remember in 2D echo, what we will find is right ventricular dilatation, because the right ventricular outflow tract is blocked because of pulmonary embolism. And a very important finding that you may get sometimes, that is known as McConnell sign. Sometimes if the thrombus is very much proximal, you can also find it in the echocardiography. So what do you mean by McConnell sign? McConnell sign is the free wall of the right ventricle will not contract, or the apex of the right ventricle will contract normally, either normally or it will be hyperkinetic, maybe hyperkinetic or maybe normal. So the free wall is affected the most because the right ventricular outflow tract is obstructed. So there will be ischemic changes to the free wall. So free walls will not contract, but the apex will somehow retain its blood supply and it will be able to contract normally, or there may be hyperkinesia of the apex, and that is known as the McConnell sign. Now the last one is VQ scan. VQ scan is done for those patients. Actually, this investigation was previously the investigation of choice. With the advent of CTPA, it is no longer the investigation of choice, but it is still preferred in those cases where CTPA is contraindicated. So, for example, if the patient is having renal failure, you cannot give contrast. So, in those cases, you may prefer ventilation perfusion scan. In this, we'll check the ventilation through some inactive isotopes, that is xenon and krypton, and the perfusion will assess through albumin labeled with gamma emitting radionucleotide. So these radionucleotide albumins will be infused into the blood, and will with the help of that we'll see the perfusion. At the same time, we'll assess the ventilation. Whenever there is a ventilation perfusion mismatch, that means there is a pulmonary embolism. Okay, so because in pulmonary artery there is a thrombus, blood is not flowing to that segment. However, the ventilation will be maintained because the patient is inhaling this gas. So ventilation will be there to that place, but perfusion will not be there because of the thrombus. So that is known as the ventilation perfusion mismatch. This is assessed by a criteria that is known as Pupet criteria, but it's not important. There is something called high probability scan. What is the definition of high probability scan? Two or more segmental perfusion defect in the presence of normal ventilation. Okay, so two or more segmental, this is important. The definition, two or more segmental perfusion defect is known as high probability scan. That means there is a high chance that there is a pulmonary embolism. Okay, so this is VQ scan, VQ scan. So these are the non-invasive imaging modality. Invasive imaging modalities include the conventional pulmonary catheterization, conventional pulmonary catheterization. That means directly will catheterize the pulmonary artery and will search for the thrombus. Another one is contrast phlebography. Contrast phlebography. However, these things are not used now. Invasive modalities are not used now because we have good non-invasive modalities to diagnose with confidence. However, pulmonary catheterization is used if you are planning, if intervention is planned. If intervention is planned, that means if you want to do a catheter-directed thrombolysis, then this can be done. Otherwise, there is no other indication. Now, coming to the management part, the treatment part, for DVT, if it is a symptomatic, proximal DVT, if it is a symptomatic proximal DVT, we can go for catheter-directed thrombolysis. Otherwise, generally for DVT, we do anticoagulation. For pulmonary embolism, for acute pulmonary embolism, if it is a non-massive, then the treatment of choice is anticoagulation. How to do anticoagulation? First, you have to start with IV anticoagulation. Most of the times it is heparin. IV or sub-Q. If you are giving unfractionated heparin, then IV. Otherwise, always we prefer low molecular weight heparin, that is sub-Q. Then we bridge with oral, that is warfarin. If you want to learn it in detail, then I have already I have lectures on these anticoagulants. So you have to look into that lecture to understand this process of anticoagulation. So I'm not going to explain it in detail here. Okay, so the management is anticoagulation. If it is a massive, what do you mean by massive? Massive means either there will be hemodynamic compromise, that means if the patient is having hypotension, systolic blood pressure is less than 90, or there is severe RV hypokinesia. So these are the indication that the patient is having massive pulmonary embolism. In those cases, we can do fibrinolysis. Fibrinolysis is done with recombinant tissue plasminogen activator. If you are using this, then this can be used, or streptokinase also can be used. This is 100 mg over 2 hours. This is 2.5 billion units IV start, followed by 1 lakh per unit per hour. 1 lakh unit per hour for 24 hours. And this will be, of course, followed by anticoagulation. And remember, very important point, fibrinolysis can be done up to 14 days. This is important to remember. What is the role of catheter-directed thrombolysis? It's very limited role, usually not much in use. Embolectomy also not much used. Can be used. Okay, catheter-directed thrombolysis, even though it is not much used, it still can be used if you want to reduce the dose of thrombolytic agent. Normal systemic thrombolysis, we are giving a very high dose of streptokinase. If the patient is, if you are thinking that patient will not tolerate this much of high dose, and if you want to reduce the dose, you can go for this catheter-directed thrombolysis. Embolectomy is if everything fails, if thrombolysis fails, or it is contraindicated. If thrombolysis is contraindicated and the patient is having massive pulmonary embolism, then you can go for embolectomy. Again, embolectomy and catheter-directed thrombolysis are done very rarely, but these are some of the indications that you can remember. Pulmonary thromboendarterectomy, this is not done for acute cases, this is done for chronic thromboembolic pulmonary hypertension. More on this we'll be studying in pulmonary hypertension. Just remember, pulmonary embolism in a long term can lead to chronic thromboembolic pulmonary hypertension that will lead to, for that we can go for pulmonary thromboendarterectomy. Now the last point, what is the indication of IVC filter in patients with DVT? Remember, IVC filter will prevent migration of thrombus from lower limb into the pulmonary circuit, but we have only two indication. That means if there is contraindication to anticoagulation, that means if the patient is having bleeding or bleeding tendency, you cannot give anticoagulation. In those cases, we have to put IVC filter. Otherwise, if there is venous thromboembolism to pulmonary circuit, that means pulmonary embolism despite the patient is on anticoagulation. Okay, so if the patient is on anticoagulation for DVT and still the patient develop pulmonary embolism, then we have to be extra cautious and you have to put a IVC filter. Otherwise, if there is a contraindication to anticoagulation, then you have to put IVC filter. These are the indications for IVC filter. So this is in a nutshell for about pulmonary embolism and DVT, and we have to look into the lecture of anticoagulation to understand it even more better.